starting the slideshow, and I will welcome you all. Thank you so much to all of you. I'm Karen Campbell, one of the co-chairs of the steering group for the COVID-19 and Cancer Global Modelling Consortium. We're really delighted to have you here today. This is the first of two calls. We have the other in 13 hours time, which will be better, we think, for our North American colleagues, and as always we will spread the information presented over two calls. So I'd like to wish you the very best, good health from wherever you're calling in from. I know these are difficult and challenging times, and we hope that through the work that we're doing we'll be able to contribute to part of the solution. So without further ado, I want to introduce my co-moderators today, both from the International Agency for Research on Cancer, Dr. Freddie Bray and Dr. Isabel Segura-Timon. And Freddie and Isabel will help me moderate through the session. We have a lot of information to present today, so we wanted to apologise in advance. We do not think there will be much time for discussion, so please use the chat box to log any and all comments. We will be recording the session and logging the comments. And we will really rely on those as a communication channel. So again, apologies in advance. This is going to be a rapid information update, and we'd ask all presenters to please move as quickly as possible through your slides. We've got a lot to get through, but the good news is that means we've obviously been very productive as a consortium, and we're excited about what you'll be seeing today. So I'll hand over now to Freddie to take you through the agenda and the aims of the meeting.
Thank you so much, Karen. Welcome everyone. Yeah, indeed, a very, very busy meeting. So just as you know, the COVID-19 Cancer Global Modelling Consortium is about bringing together the modelling community and supporting decision-making in cancer control. And we're going to hear about what's been happening in the three working groups, and as Karen says, there's been a lot. So on treatment, on screening, and on prevention activities, there's going to be a lot. So we're going to go through that very rapidly, the current status. We're going to talk about the COVID and Cancer Observatory. Karen and Isabel are going to introduce that topic, and we're also going to flag the opportunities that we all have to participate in the systematic reviews that are ongoing. So just to reiterate, please use the chat to take any questions and comments. We'll try to get to those at the end if we rush through the slides fast enough. Next, please, Harriet. Yeah, so this is the agenda, and I don't want to dwell too much on this, but as you can see, there's quite a lot. We're going to hear very happily from Professor Richard Sullivan in a moment on the Cancer Task Force. We'll get updates on the consortium overall from Karen, and then we're going to get a bit more in depth into the working groups, and then have an open discussion about what you've heard, but also specifically on the COVID and Cancer Observatory. Next, please. Yeah, and so here we are with Richard. So we're going to put it over to Richard. Of course, the Cancer Modelling Consortium is one of the work streams of the Cancer Task Force, which was set up and is chaired by Richard Sullivan. Richard, over to you on an update on the COVID-19 and Cancer Task Force, please. And you've got about 5 minutes, as you may have seen.
Thanks, Freddie. Thanks so much. That's good. That's all I need. Karen, thank you also. Lovely to see you all. Next slide, please. Great. Oh, I think we're missing one. Can you just go back one? Okay, that's okay. Next slide, please. Great. So maybe I'm just going to start by just saying that there's been a lot going on with the task force generally. We've had a lot of engagement, both national and international, in terms of symposium, webinar series. It's all on the main website. One of the things I think maybe to talk about later on is about building up more educational outreach and capacity. Next slide, please. So basically this has grown now. We've now got nearly 72 members across 47 countries, varying in size. We've got about 9 projects, and we've got a long list basically of collaborative networks now. So far about 30 publications in different areas. And we've looked at basically what other people are doing across the task force, and we think about another 11 are near completion. 3 major objectives. I won't go through those for the sake of time, but they're the same objectives we've had from the very beginning. Next slide, please. One of the first big things was the health worker survey. This is the working groups led by Chris Booth. You can see all the countries there that are involved in this. It's a major piece of work, a lot of individual country level analysis, and this is going to be followed by a meta-analysis. It's looking at the perceived stress and resilience to inform organisational strategies around the mental health of healthcare workers during the COVID-19. There have been some remarkable successes here. Japan has an incredibly complex study. It's now into its third wave of analysis. So I think we're going to see some really interesting data coming out from this working group. Next slide, please. We've got an economic impact working group. We've already had the first publication that led from Malaysia, from Nirmala Bupati. Ajay Agarwal and Bernard Rache are about to publish a major piece of work on the economic impact of delayed diagnosis. I think he's online, so I'm sure he can talk a little bit more about that if people have questions. Michael Schlander's also got an ongoing major German study with the DKFZ. And we're also now starting to increasingly work with the OECD because they're increasingly interested in the wider economic impact of loss of productivity due to premature mortality and morbidity in cancer. Next slide, please. We've also got an interesting group working on research impact. So what's been the impact of the COVID pandemic on global research? This is a reasonably developed stage now. We've got a very in-depth bibliometric analysis of all publications, which basically coincide with COVID and cancer. That's near completion and now at the moment. That's being led by Mika von Hemmelrich, Debbie Mukherjee and Werner van der Pie. We've got this survey data that Louis Fox is rolling out at the moment. That's still relatively low resolution, but the resolutions I think are increasing on that. And we're looking to sort of publish that in Q3 of this year. Next slide, please. There's a very large number of people looking at risk and the indirect impact working group. A lot of work is mostly underway in high-income countries from the quant side, and we've already talked about, again, the work that's been done by a lot of the countries, but they're mainly from single centres, and actually from when you look at the LMIC data, a lot of this is just qualitative narrative research. The risk picture is very complicated. There's lots of publications coming up from hospital cohorts, global cancer surgery, etc. But I'm going to say this now generally, there's a huge problem with ascertainment bias and variation in methods used to calculate the risk of COVID-19 to cancer patients. We've, for instance, recently published the indirect impact of MPIs just on Guy's and St Thomas's patient cohort in London, but we know there's a lot of other people looking at this sort of data, and particularly around stage shift. Next slide, please. And this is really the final slide, the one I want to spend probably the most time on. The latest piece of work, which is just going to come out in Lancet Oncology, I think next week, is a major commentary and analysis around availability of COVID-19 vaccines for cancer patients. And it's coterminous, I believe, with two major studies. One Israeli data with vaccine for cancer patients, and another one, again, from Guy's and St Thomas's, looking at the sequencing of vaccines in terms of immunological reactions from patients in terms of actually getting immunity from these vaccines. The picture is incredibly complicated. These are just the major vaccines we've picked up from around the world. There's obviously a very large amount of work that needs to go on to look to see, first of all, whether patients are receiving these vaccines, first of all. Secondly, whether they're actually developing immunity to COVID-19. And the variation we've picked up and the heterogeneity is amazing. The good news is a lot of healthcare workers in a lot of countries are now being vaccinated, less so with cancer patients. And of course, there's still a huge gap between many countries like sub-Saharan African countries accessing vaccines to the COVAX network and actually what we're getting in high-income countries. So as everyone knows, a huge amount of vaccine nationalism. But as I said, this I think is going to be a really interesting and fruitful area for prospective studies going forward, both in terms of data science and also immunology. And that is it. That's a very rapid digest of an enormous amount of work. So just to say thank you very much to everyone and all my colleagues on the task force. This is really all of their work. Back to you, Freddie.
Thank you so much, Richard. That's brilliant, and thanks for being so rapid and precise and going on about the activities. So over to you, Karen. You're going to give an overview of the current consortium activities.
Thank you so much, Freddie. Thank you, Richard. Just very briefly, because we'll hear more about it in the working group updates, I just wanted to acknowledge the publication pipeline for the consortium. So congratulations to the colorectal cancer project team within Working Group 2 for their Lancet GE publication, and also to acknowledge the work done by Afira Ginsberg and other colleagues and myself on our commentary piece on elimination of cervical cancer in the context of COVID-19. But if we just go to the next slide, we actually have a huge pipeline. So some of the publications in process are noted here, and I'll leave it to the groups themselves to talk to some of the results coming out of these different studies, but they include, of course, important systematic reviews as well as comparative modelling exercises, and we'll hear about both today. So if I move on to the next slide, the concept that we wanted to introduce to you all today for as much discussion as we have time for is really establishing a resource as we go forward to make the best use of all of the insights that we are gleaning from the work that the consortium is progressing. And what we would like to propose that we as a consortium consider is that we turn some of the work programs that we're engaged in into something like a living COVID and cancer observatory. Now, in saying this, the last thing that we want to do is overlap with the efforts of others. So clearly a big piece of this will be making sure that we understand, if you like, the landscape of activities in COVID and cancer control. But nevertheless, there are important areas in which we think that our activities will provide an ongoing living resource for professionals in cancer control, policymakers, clinicians, and all involved in this space. So the initial proposal is that we look at some of the systematic reviews that we have been engaged in, and you'll hear, as I say, you'll hear more about those today. The three big ones underway at the moment, which are just maturing now: risk of death from COVID for people with cancer, risk of infection with COVID for people with cancer, and smoking behaviour changes during the pandemic. One of the things that we propose to do is to turn this into literally a living resource where we as a consortium stay on top of this literature as it emerges, that risk of bias, for example, is assessed, and that there is a resource on a website that will give an ongoing picture of this literature, and that periodically we would then kind of cut and publish results in the peer-reviewed literature. The second line there is a set of reviews that are on our radar and have been suggested by many of you, and we're working with some of you on working up these ideas about future topics for us to consider. And I'm just going to put them out there now for you to think about through the call, to consider a systematic approach to staying on top of the literature around screening-related disruptions and recovery strategies, COVID vaccine and impact and outcomes in cancer patients. As Richard just said, this is an incredibly complex space. Again, without wanting to overlap with the activities of others, there will be enormous realms of observational data as well as the trial data that will emerge, and it will be difficult, I think, to keep on top of it. Is there a role for us there? Impact of diagnostic and treatment delays, and that's picking up on an important review published by Tim Hanna, who is here, published in the BMJ last year, which Tim is keen for us to take and make into a living resource and keep updated. And then there's a possibility of Working Group 3 continuing what they're doing with this exciting review of smoking behaviour and extending it to other risk factors for cancer. So this is our idea, that this observatory would be living systematic reviews and also the modelling results to go with it, so that policymakers, clinicians, patients and all stakeholders have a place to go to understand the latest evidence on COVID and cancer. So just moving on to the next slide. So without further ado, we'll come back to that idea of the observatory at the end for a little bit of discussion. But before we do, I'd like to now hand over to Isabel, who will take us through the Working Group 1 activities. Isabel, over to you.
Good morning, everyone, and good afternoon then for some of you. So today we'll have then the Working Group 1 overview to start with. This is really then the working group that works a lot on looking into the treatment and outcomes that's related then to the COVID-19 and cancer. we'll have then 4 major overview that we'll go through quickly, but then we'll start with the mapping of the data and how this take us into the next step of thinking of priorities and focusing some of our more closer to the future work. Next slide. We'll then give an overview, Chelsea, then at the moment on the systematic reviews that are ongoing within the working group 1.
Thanks, Isabel. So I'll be presenting the results of 2 systematic reviews. The first looks at the risk of contracting SARS-CoV-2 or developing COVID-19 for people with cancer. And the second looks at whether COVID-19 patients with cancer have a higher risk of death than those without cancer. Our preliminary scoping of the early evidence identified a number of methodological issues. Therefore, we not only synthesised the evidence, but also aimed to critically appraise these studies for the methodological issues and their impacts. For both reviews, we searched for published and preprint evidence up to July 1st, 2020. Next slide.
Thanks a lot, Chelsea, for that very brief overview of a very large amount of work that Tim has been doing. So I'll move this now to Andre or Felipe, who's then going to present on this.
So again, my sincere gratitude for all the members of our cancer team, including here Dr. Andre Bavi that's just joined us. He was not able to join us in person to present this meeting because of last minute issues, but I'll do this on behalf of the cancer team. So now it is to present our data and models to support this decision making, which is the COVID model that we produced here in WHO under Andre Bavi's guidance. So next slide, please. Let me see if not. Oops, now it's working. Okay, so as a principle for the model, we just addressed what were the root causes, the data, and the parameterization to build up the model that we're going to present it to you. So as we know, cancer and COVID interaction has impacted cancer patients dramatically due to diagnosis delays, treatment services that were not accessible, optimal treatment that were not available, which means that the quality of the services offered was reduced or changed, treatment abandonment, and also the trade-offs related to exposing cancer patients to the cancer care, and at the same time, the risk of getting COVID and contracting the disease and getting severely ill. That's one of the systematic reviews that you are now producing. So this trade-off, firstly, the medical community didn't know how to handle that, and the unintended consequences of these disruptions also probably will impact on cancer patients and also in the healthcare system. So to try to analyze and build up this model, we started collecting data. And as you know, WHO produced the pulse surveys that was not cancer specific, but also addressed cancer in a high level estimates and response from the countries. As we know, 90% of them had disruptions in NCD care. And also we provided and we addressed 2 systematic reviews. We produced it to analyze the impact of COVID in terms of services disruptions and delays for cancer care, and also the mitigation strategies. As you know, we have a substantial impact on services, but only 9 countries which refer the limited strategies related to mitigation strategy related to outcomes. So the literature quality at that time was poor, and we know that only a few studies regarding mitigation strategies offered the data that we wanted regarding outcome-related mitigation strategies. And as we know also from these studies, 36 different disruption points were detected from our study. Also, we collected data from childhood cancer database to build up the model with the aim of offering analysis for health impact, system impact, financial considerations, and mitigation strategies. So as you see here, just a snapshot of this model that's Excel-based. We can offer inputs based on baseline assumptions provided by our previous model for prioritization for cancer investment. So we are able to select the country profile, selected what's the timeline of COVID duration to analyze the impact of COVID during the time that's happening, and also the consequences after it's finished. And it can be also tailored according to each of 14 cancer sites, as you see here. The CH1 and 6 stands for the 6 index childhood cancers. We can also define the delivery reduction percentage in terms of abandon and delivery reduction. Alterations in care are included here, for example, in the quality analysis for this impact. And we also can define the timeline related to delays in care distribution and how to recover after the pandemic. So it's a very granular system based on our data collected from systematic reviews and also the model. So here is just to give an impression of how should we present data. Here I'm comparing this to you in a country estimate from a low income country. And as you see here, the blue line and the gray line refers to the reference, and the yellow and orange line refers to the intervention. So we can define, for example, for a given country that wants to adopt a benefit package of interventions, that want to expand their intervention, the benefit package from tier 1 to tier 2, and has 30% delivery reduction, we can model the impact. But mostly, more than defining how many deaths are occurring, we want to give them the impression of what is the benefit in terms of life saved, not the lives lost. So we can shape the dialogue to define and to decide that, and to give the message that investing in cancer care is still needed, and recovering the healthcare system according to that points identified by our systematic reviews and addressing them properly is important to save this amount of lives that you see here. Also, we are here another example of how can we manage this information of different scenarios. So here 30% delivery reduction and below 50% delivery reduction. So you can describe what's the impact of also recovering the reduction in the delivery services. Here global estimates, just to give you the impression of that country that I showed you is a low income country. And when you see the global estimate that we are also possible to generate the impact of the interventions. So you see here, the slope of the curve, orange to yellow, is much more important because of the impact that is different from low income country settings and high income country settings, also shaping this dialogue of how important it is to tailor the interventions according to each cancer, to each country, but also to build up a better and resilient cancer care. So what is the sample for our full guidance here? Define and maintain or modify essential services to mitigate the impact, adapt treatment services for different phases, organize committee for rapid review and improvement cycles during the pandemic phases. So we're not waiting, we can act now regarding this proposal. So as a conclusion and next steps, we oversee as ongoing collection of data from WHO, but from our partners also, IR, Global Childhood Cancer Community, systematic reviews as the one that you're producing now. So this data will be really beneficial to fit this model and try to dialogue with the countries what's the impact of investing in cancer care and how important it is to build it back better. So also there are other proposals to improve the dialogue, publishing results from model with positive message, as I've mentioned during this discussion, in the context of mitigation strategies, support the ongoing dialogue with governments regarding the adoption of NCCP, specifically addressing also not only the health impact, but the financial impact that we build up this tool over the top of our costing tool, and in collaboration in strong partnerships appreciated to advance dialogue, support patients. And finally, I would just like to conclude that this is not only for COVID, but for any disruption that we frequently see as civil wars, disasters, natural disasters that disrupt the system in an acute way. So I think this goes beyond, and this collaboration with this modeling group will be really important to leverage this work and provide the message that we want to member states in engagement. So again, I'd like to thank you for your attention, and specifically Andreu Bavi, who's joined us now, for his guidance in this project. Thank you.
Thank you so much for that, Felipe. I'll move, in the interest of time, I'll move this quickly to picking up again on the global platform that we're also working on at the moment. Kirsty is then presenting on this one. Kirsty.
Thank you. The aim of the global modelling platform is to create a survival-based simulation of cancer burden across the globe. This model will incorporate information from multiple different countries for cancers of interest. Initially, we're aiming to look at breast, colorectal, lung, and cervical cancer for the first stage of the model development. Next slide, please. The simple structure of the survival model looks like this. An individual enters the simulation as well and progresses through undiagnosed or asymptomatic disease to a stage diagnosis. Individuals can then survive their diagnosis depending on their stage at diagnosis. This simulation requires relatively little data to mimic global cancer burden. The incidence of diagnosis can be taken from GlobalCan incidence rates and the survival associated with diagnosis from SURVMARK2. We can then implement stage shifts and survival decreases, which we'd expect from diagnosis and treatment delays. The estimated impact of COVID-19 on treatment provision and its associated decreases in survival will be based primarily upon the paper from Hannah et al. And also other emerging data sources from systematic reviews as they emerge. Thank you.
Thank you very much. And if I could just make a comment, you've seen just now the presentation of 2 platforms in development, and I think I want to thank Felipe and Andreu Bavi and the WHO team. We're having a very productive set of discussions around making sure that our efforts synergize, that we share data sources where appropriate, and we think that the different platforms will have different strengths to bring to bear, and that there should be value in comparative modelling. I also wanted to note, just as we go into the Working Group 2 updates, that one of the key reasons for the choice of priority cancers as outlined by Kirsty was that we hope to connect in with the Working Group 2 simulations of the effects of screening disruptions and early detection effects. And so that will be part of our agenda going forward as well. So without further ado, I'll hand over now to Iris, who will take us through the Working Group 2 updates.
Thank you very much, Karen, and thank you very much all for participating in this webinar. I'm very pleased to introduce 3 speakers later that will give an update on what's been going on in the colorectal, cervical, and breast cancer screening working groups. But for now, I would like to start with a short update on the International Cancer Screening Network. As I've told during a previous meeting, spring and summer last year, the International Cancer Screening Network did a survey on whether screening programs were disrupted worldwide and how the decision to stop screening programs was made. And currently the results of that survey are being written up, and we are already in the preparation phase of putting out a second survey that we hope to do also in the spring, with the lessons learned from the previous survey, that it can go a little bit smoother and faster. What we hope to get in that survey is to get more information about how long screening programs had been suspended, what the capacity was of the programs when they started up again, what the impact is on participation, whether people are being caught up, missed individuals on screening, and how people prioritize the backlog of missed screens. So that's going to be a second survey. And the third initiative by the International Cancer Screening Network is that we are working on a data monitor to try and really get quantitative data on the impact of COVID-19 on cancer invitations, cancer screening invitations, cancer screening participation. We start with colorectal cancer, and the survey has already been sent out, so I can imagine that several people on this call will actually have received a call for participation, so I hope all of you will be able to participate. And the idea is that this data monitor that started with colorectal cancer, but hopefully will be expanded to include breast and cervical as well, that we can use that as inputs for the modeling exercises that we're doing here at the COVID and Cancer Global Modeling Consortium, so that we can have more realistic scenarios to simulate in the future. There's a lot going on, as you can tell. If you want to know more about it, on May 10th at 6 p.m. Central European time, there will be a webinar, which is actually a joint webinar between the ICSN and the Cancer Global Modeling Consortium, COVID and Cancer Global Modeling Consortium, where we give a presentation on our work. So we will share the details for this webinar shortly after the call. So if you're interested, please let us know and you can participate in that call as well. That's enough, I think, about ICSN. Now I would like to give the floor to Francine van Wifferen to give an update on the colorectal cancer working group.
With this colorectal cancer screening working group, we are working on several projects. And in this first project, we have evaluated the impact of a short-term disruption to the colorectal cancer screening program due to the pandemic. And we have projected the impact on long-term cancer incidence and mortality over 30 years. This paper has now been published in the Lancet Gastroenterology and Hepatology. Next slide, please. And in the second project, we are evaluating strategies to clear the backlog in colorectal cancer screening due to the pandemic using limited colonoscopy resources. For all strategies, we evaluated a 3-month disruption period to screening. And then we simulated that catch-up screening was performed at a regular fit threshold in 6, 12, and 24 months. This means that after a recovery period of 6, 12, or 24 months, the screening backlog has been cleared. The second set of strategies also consisted of catch-up screening in 6, 12, and 24 months. But now the fit threshold for referral to diagnostic colonoscopy during this catch-up screening was increased. Since individuals with higher hemoglobin levels are at a higher risk of more advanced lesions, these strategies refer individuals at higher risk for a diagnostic colonoscopy. We evaluated country-specific fit thresholds because the fit thresholds that are used in the different countries varied. For the 2 models evaluating screening in the Netherlands, we simulated the fit threshold that is currently used, 47 microgram, and we increased this threshold in several steps to 80 micrograms. And for the 2 models evaluating screening in Canada and Australia, we evaluated thresholds between the 20 and 60 micrograms. Next slide, please. Due to time, I will only briefly show you some of the results from the ASCA model for the Netherlands. And in this graph, you can see on the left the monthly change in colonoscopy demand during the recovery period that is required to perform the catch-up of screening. A 0% change to the usual demand refers to the usual demand that would have been expected without a pandemic. And on the right, you can see the total number of excess colorectal cancer deaths in 2020 to 2050 that can be prevented by performing catch-up screening. 100% prevented means that all of the excess colorectal cancer deaths due to the disruption are prevented. And you can see here the results for 6, 12, and 24 months recovery period. Each bar represents the different thresholds that are used for the catch-up screening during the recovery period. The lightest gray bar corresponds to screening at the regular thresholds, and the darkest bar at the highest threshold. Could you click once for it? Yes. The 2 main results that we found are that first, when catch-up screening is performed at a regular threshold, almost all of the excess colorectal cancer deaths can be prevented. Additional colonoscopy demand is required to do so, and when the recovery period is extended, still most of the excess colorectal cancer deaths can be prevented. But the additional monthly colonoscopy demand that is required to achieve this diminishes. Thus, if a limited increase in colonoscopy services is feasible, the period to clear the screening backlog can be extended to 12 or 24 months, while still preventing most of the excess deaths. Could you click once again? And the second main result is that if the usual colonoscopy demand cannot be exceeded, still approximately 50% of the excess deaths can be prevented by increasing the fit threshold that is used to perform this catch-up screening for a limited amount of time. For the other 3 models, OncoSim, Policy1 Bowel, and MISCAN colon, a similar trend in results was observed, and this work has now been submitted for publication. Next slide, please. And now we are working on, we are moving on to project 3. And this project is currently planned to be an expansion on the first project, which modeled hypothetical screening disruption in the Netherlands, Australia, and Canada. And now that real-world screening data are available, we can repeat the simulations and expand on the analyses. Data permitting, it may also be possible to model the impact of disruption that occurred in other countries. We, along with ICSN and our dedicated working group, are identifying sources of data to inform this work with the aforementioned survey. If you have any other sources of detailed screening data that you think may be of relevance, please let us know by email. Thank you, and I will hand over to the cervical team.
Yes, thank you very much, Francine. And I would like to give the floor to Emily Berger for an update of the cervical team.
Fantastic. Thank you so much, Iris. On behalf of the working group, I'm pleased to present our ongoing activities and our future directions. Just a reminder, our cervical cancer working group is co-chaired by myself, Dr. Megan Smith, and Alex Castanon. We are about 20 people who have interest in the working group, but about half of us meet regularly every 2 weeks. Next slide, please. So our first analysis is a piece of original research and has been presented at the previous CCGMC wide meeting. For this analysis, which is being led by Dr. Smith and is titled The Impact of Disruptions and Recovery for Established Cervical Cancer Screening Programs Across a Range of Program Designs Using COVID-19 and as an example, a modeled analysis. So we used 3 very well established modeling platforms fit to 5 different countries. Through a series of standardized screening disruption scenarios, we found that across all settings, around half or more of the excess cancer burden due to disruptions was predicted to occur in women aged under 40 years, including settings where women in their 30s have previously been offered the HPV vaccination. And approximately 15 to 30% of these cancers predicted to occur due to the disruptions could be prevented by maintaining the colposcopy and pre-cancer treatment services during the disruption period. Disruptions to primary screening led to a relatively more excess cancer cases in situations where women had cytology as their previous primary test as compared to primary HPV testing, which is more sensitive. Rapid catch-up would dramatically increase demand for HPV tests in 2021, which it may not be feasible to meet because of the competing demands on testing machines and reagents due to COVID-19 tests. Next slide, please. So our second output is a viewpoint that was recently accepted to Lancet Public Health and was led by Dr. Alex Castanon. We used our experience modeling cervical cancer screening outcomes to advocate for risk-based strategies as the most effective and efficient way for screening services to recover. So we cautioned against performance measures that rely solely on restoring testing volumes to pre-pandemic levels, as they'll be less effective at mitigating excess cancer diagnoses, particularly among those at highest risk. They may exacerbate pre-existing inequalities in accessing cervical screening by disregarding the risk profiles of those attending. We detailed several potential strategies for effective recovery to allow for flexibility, and we recognize that programs differ in their capacity to implement detailed risk-based approaches. The degree to which screening is organized will be determined by the feasibility of deploying some risk-based strategies, but implementation of age-based risk stratification could, in theory, be universally feasible. Next slide, please. So then we're actively participating in multiple cervical cancer and screening networks, including presentations at the HPV Prevention Board's 2-day working group meeting, where our working group members presented ongoing work. We are planning to present at the ICSN COVID-themed meeting in May. And then finally, we're aiming to develop a satellite symposium at the International Papillomavirus Conference in November. And then finally, next slide. Our next steps, we're keen to explore policy implications of different recovery strategies. So we have a number of discussions regarding the value of screening registries in identifying groups at higher risk for cervical cancer. So these were detailed in this viewpoint piece in the Lancet Public Health. But now we want to break down the group of women who have previously been screened negative to identify within this group those at higher risk. So for this next analysis, we would like to quantify variations in expected health outcomes from risk-based targeting of routine cervical cancer screening. So that would be targeting age, time since last screen, or the interaction of these two characteristics. And the purpose of this estimation is to clearly communicate to policymakers the most important groups of women in need of primary screening to prioritize if there are constraints on resources. And we hope that such information will be useful beyond the single example of COVID and may be applicable, for example, to extended to assess the value of targeted use of self-sampling. So we aim to convey the message that programs can be selective in returning to baseline coverage levels and use the opportunity to target screening to those that will benefit the most, while possibly realigning the balance of harms and benefits for women who may be screening too frequently. So those are our major updates, but of course I please welcome to reach out to any of us if you have any ongoing ideas or analysis thoughts. Thank you.
Thank you so much, Emily. And then I would like to move on to the breast working group, who will be represented by Carolyn Nixon. Thank you, Carolyn.
Thanks, Iris. I'll be quick. So we have produced an analysis that's also been submitted to Preventive Medicine, looking at the disruptions around breast cancer screening programs, providing a summary of those and a summary of the modelled evaluations that have been taking place. There's really quite an active area using established breast models, including the models represented in our working group. We discussed the common themes in those modelling exercises, such as modelling a range of assumed causes, the focus on tumour staging and mortality as outcomes. We noted that emerging cancer registry and screening program data would be very valuable for future modelling, and identified priorities for future modelling exercises, including population level outcomes, treatment intensity, inequities within populations, high level modelling in LMIC settings, and making sure that we're engaging stakeholders. So next slide, please. So looking forward, we want to regroup as a group and look at what has been published and identify the key gaps that we can address collectively. We're keen to continue to document and estimate the disruption to breast screening, and it's fabulous to hear the ICSN survey is being repeated. We'll continue reporting and consolidating results, and the observatory will be a fabulous tool, we think, to support our group's efforts. We'll characterise impact on referrals to treatment services. That's our real goal, we think, is to synthesise the work that's being done to really generate estimates around case mix of diagnoses and those downstream impacts for such a common cancer. And ideally work together to estimate the impact and cost effectiveness of catch-up and adaptation strategies using the various models represented in the group. So we'll get back together in next month. Thank you.
Thank you very much. Well, we are very mindful of time, but we're going to spend a few minutes, a very few minutes. Please, Working Group 3, we're so sorry to cut you short, and we'll make sure you have more time at the next meeting. But over to you, Isabel and Peter Sarich.
I will just immediately hand over to Peter, who's then going to present this work.
Thanks, Isabel. So our PICO question for this review was, is the COVID-19 pandemic associated with changes in tobacco smoking behaviour? And so our outcomes were in a range of things: intensity, prevalence, frequency, uptake and initiation, cessation, patterns, and also quit attempts and intention to quit. Next slide, please. So we are most of the way there now. We're currently just in the meta-analysis and synthesis stage, and also we're currently drafting the manuscript. And so at the last CCGMC meeting, we issued a call out just for local lifestyle surveys and studies on not just tobacco but any risk factor in relation to the COVID pandemic. And we received 26 submissions so far, covering 31 countries. And we'd just like to remind you that, at any time, if you encounter any more surveys, please feel free to send it through to our drop form again.
Thank you, Peter, for that. So just to wrap up as well, we're finalizing this first work on then smoking and then also determining then the future steps which will be brought up in this overall discussion. So we're really looking forward to your comments or inputs of what you may think are important and should be a priority then in this working group 3 on the prevention side. Karen, I hand this over then to you again.
Thank you so much. So unfortunately, we are just at time. So I'll ask Carrot just to move a couple of slides forward. We do want to leave you with this idea of the COVID and Cancer Observatory. What we would like you to take away is some consideration of the priorities for our investment in ongoing reviews and modelling questions. These are all, the systematic reviews will obviously be tightly linked to modelling. Here in front of you is a list of our current topics under consideration. We'd love to hear from you about your views on the prioritisation and importance of these topics as we go forward. If we could just move to the next slide. We just also wanted to thank 40 members, thank you, because 40 members of the CCGMC have signed up to get involved in systematic reviews at different levels, from data extraction to high-level supervision. And just to let you all know that we're in the process of contacting and engaging with those members, and we will be working with you to coordinate our activities. So if you are interested in participating in any of our systematic review activities for the observatory, and as I said, that these will be regularly published in the peer-reviewed literature, please contact us at the Secretariat at the email noted there. So with that, I must unfortunately bring us to a close. I just wanted to thank all of our presenters and thank all of those involved in the working groups. It is a testament, the difficulty in getting through our agenda today is a testament to how much exciting work is going on in the consortium. So following this call, we will be running it again tomorrow, but after that we will regroup and consider how best to come back to you for that ongoing discussion of prioritisation and the construction of the observatory. So please stay tuned, and thank you again for your engagement in our consortium. Bye all. Thanks to my coach. Bye.